Linking on my brain. Okay. Linking on my brain. I got linking on my brain. Whoa.
Urinary system. The two kidneys function to remove toxins from the bloodstream and to conserve water, salts, proteins, glucose, amino acids, and other essential substances. They also assist in regulating blood pressure, hemodynamics, and acid-base balance of the body fluids. Additionally, the kidneys produce hormones, such as erythropoietin and prostaglandins, and assist in the formation of vitamin D. The hemisected view of the kidney in Figure 19.1a shows that the kidney is surrounded by a connective tissue capsule that covers the outer region of the substance of the kidney, known as the cortex, deep to which is the medulla with its renal pyramids and the intervening cortical columns. Each renal pyramid drains its urine into a minor calyx, and several minor calyces deliver their urine into a major calyx whose confluence forms the renal pelvis, the expanded region of the ureter located at the hilum. Also at the hilum, the branches of the renal artery enter the kidney, and tributaries of the renal vein leave the kidney. The basic unit of the kidney, known as the uriniferous tubule, Fig 19.ib, is completely epithelial in structure and is separated from the connective tissue elements of the kidney by its basal lamina. It is composed of a nephron, cortical or juxtamedullary, and a collecting tubule. Several nephrons drain into a collecting tubule, and several collecting tubules join each other to form larger and larger collecting tubules. Each nephron has several component parts: Bowman's capsule, proximal tubule, Renal loop, distal tubule. About 15% of the nephrons, the juxtamedullary nephrons, have a long Renal loop, and rare renal corpus callus is located at the junction of the cortex and the medulla. About 85% of the nephrons, the cortical nephrons, have a short Renal loop. And their renal corpus callus is located closer to the kidney capsule. Bowman's capsule, Fig 19.ic, the expanded portion of the nephron, resembles a balloon during embryonic development and is composed of a simple squamous epithelium that is invaded by a cluster of fenestrated capillaries, the glomerulus, whose fenestrae have no diaphragms and are 70 to 90 nm in diameter. In this fashion the space within Bowman's capsule is reduced and form a narrow cavity, Bowman's space, urinary space, located between the outer and inner layers of Bowman's capsule, known as the parietal and visceral layers of Bowman's capsule, respectively. The glomerulus becomes invested by the visceral layer, all of whose cells become modified in shape and are known as podocytes. The glomerulus and Bowman's capsule collectively are known as the renal corpus callus. Where the podocytes and the endothelial cells of the glomerulus contact each other, the two basal laminae fuse. Podocytes, see Fig 19.1c, bear numerous long, tentacle-like cytoplasmic extensions, primary, major, processes, each of which possesses many secondary processes, petty cells, arranged in an orderly fashion. Petty cells completely envelop most of the glomerular capillaries by interdigitating with petty cells from neighboring major processes of different podocytes during nephrogenesis and even at birth. The kidneys display signs of lobulations, but as the nephrons develop, a smooth, convex shape is formed. Occasionally, the lobes are recognizable externally in an adult, however, and this condition is known as a lobated kidney. This condition has no apparent functional consequences. Filtration process: as the fluid leaves the capillary bed to enter Bowman's space, it has to pass through the filtration barrier, composed of the glomerular endothelium. Fused basal laminae, which trap molecules greater than 69,000 Da. Filtration slit diaphragm, Fig 19.2a and inset. The filtered fluid entering Bowman's space is called the glomerular ultrafiltrate. Because the basal lamina traps larger macromolecules, it would become clogged if it were not continuously phagocytosed by intraglomerular mesangial cells and replenished by the combined efforts of the visceral layer of Bowman's capsule, podocytes, and glomerular endothelial cells. Proximal tubule. The proximal tubule has two regions: long, highly tortuous pars convoluta, proximal convoluted tubule, located near the renal corpuscle; shorter, straight pars recta, descending thick limb of Heim's loop, that dips into the medulla, where it joins the descending thin limb of Henle's loop, Fig 19.2b. Both regions of the proximal tubule are composed of a simple columnar epithelium with a well-developed apical striated border of densely packed microvilli, an endocytic apparatus richly endowed with endocytic vesicles, and intricately interleaved and interlocking lateral cellular processes. The proximal tubule is responsible for reserving 60% to 80% of the water, sodium, and chloride, 100% of the proteins, amino acids, and glucose, and toxins from the ultrafiltrate that enters its lumen from Bowman's space of the renal corpuscle. An adenosine triphosphate, ATP, powered sodium pump, located in the basal cell membrane, drives sodium into the connective tissue stroma, and chloride follows passively to maintain electrical neutrality. Water follows to maintain osmotic balance via aquaporinae channels, reducing the volume but not affecting the osmolarity of the ultrafiltrate. The endocytic apparatus is responsible for the resorption of the larger macromolecules. Thin limb of Heim's loop. The thin limb of Henle's loop, composed of a simple squamous epithelium, has three regions: straight, descending thin limb; hairpin-shaped Henle's loop; straight ascending thin limb that joins the distal tubule, see Fig 19.2b. Although the thin limb may be absent in cortical nephrons, in juxtamedullary nephrons it is almost 1 cm long and may extend far into the medulla, reaching the renal papilla. The descending thin limb is completely permeable to water, urea, sodium, chloride, and other ions, whereas the ascending thin limb is relatively impermeable to water, but is permeable to urea and most ions. Distal tubule. The distal tubule, composed of a simple cuboidal epithelium, does not have as rich a supply of microvilli or as complex lateral interdigitations as do the cells of its proximal tubule. The distal tubule has three regions, see Fig 19.2b. Pars recta, ascending thick limb, which is the continuation of the ascending thin limb of Henle's loop. Very short macula densa. Distal convoluted tubule. Minimal change disease, is the most common kidney disorder in children. Adjacent petty cells seem to fuse with each other, resulting in proteinuria. In most cases, corticosteroid therapy successfully treats the condition. Heroin-associated focal segmental glomerulosclerosis occurs subsequent to long-term intravenous use of heroin, resulting in significant proteinuria with irreversible uremia in 2 years. The syndrome occurs mostly in African American men younger than 50 years old. The disease attacks podocytes, causing some of them to degenerate and to lose contact with the basal lamina. The best treatment is elimination of heroin use, but in most patients progression to end-stage renal disease that would possibly require dialysis or renal transplant occurs. The pars recta of the distal tubule is almost 1 cm long, and its cells form very effective zonuli occludents with their adjacent neighbors, forming an efficient barrier between the lumen and the surrounding connective tissue stroma and thus preventing material from taking the paracellular route. The pars recta is highly impermeable to water and urea, but its cuboidal cells possess basally located chloride, and perhaps sodium, pumps that deliver Na and Cl into the connective tissue, reducing the Na and Cl* concentration of the ultrafiltrate in the lumen of the pars recta of the distal tubule to such an extent that by the time it reaches the corticomedullary junction, it is quite hypoosmotic, but the concentration of urea remains high, see below. The macula densa, located between the afferent and efferent glomerular arterioles in the vicinity of the distal tubule's own renal corpuscle, is part of the juxtaglomerular apparatus. The distal convoluted tubules, Fig 19.3a, are less than 5 mm in length, are impermeable to water, and drain their ultrafiltrate into the collecting tubules. The columnar cells of the distal convoluted tubules possess aldosterone receptors and NAKAT posse sodium-potassium exchange pumps, both basally located. Binding of aldosterone to its receptors activates these cells to transfer sodium, and, passively, chloride, into the renal interstitium, reducing the osmolarity of the ultrafiltrate even further. The juxtaglomerular apparatus, function is described later, is composed of three parts: the macula densa, juxtaglomerular cells, and extraglomerular mesangial cells, Fig 19.3b. Nuclei of the narrow, pale cells of the macula densa are very close to each other and appear as a dense spot, hence the name. The basal lamina is absent between the macula densa and the juxtaglomerular cells. Juxtaglomerular cells are modified smooth muscle cells of the afferent, and frequently, efferent glomerular arterioles. These cells synthesize and store renin, a proteolytic enzyme that converts angiotensin O again into angiotensin I. These cells also contain angiotensin converting enzyme, angiotensin I, and angiotensin II. Extraglomerular mesangial cells occupy the space between the afferent and efferent glomerular arterioles. They may also enter the renal corpuscle, where they are known as intraglomerular mesangial cells. Collecting tubules, the second part of the uriniferous tubules, the collecting tubules, are approximately 2 cm long and have a different embryologic origin than the nephrons. The two become connected during embryonic development. Collecting tubules are composed of a simple cuboidal epithelium. They have three regions: cortical, medullary, and papillary, and during certain conditions, they modify the ultrafiltrate that they receive from nephrons. Cortical collecting tubules are located in the medullary RAS, and their cuboidal epithelium is composed of principal and intercalate cells. Principal cells possess only a few, short microvilli, and their lateral cell membranes are smooth with only a few interdigitations with neighboring cells. Principal cells possess aquaporin II channels that are sensitive to antidiuretic hormone, ADH, vasopressin. Intercalate cells are of two types, type A and type B. Both cell types possess numerous apically located microplici and vesicles. Type A cells transport H into the lumen via apically located HAT posse and acidify urine. Type B cells have basolaterally located HAT posse and resorb H and secrete HCO*. Several cortical collecting tubules join each other to form larger, medullary collecting tubules that increase in diameter as they progress deeper into the medulla. The tubules in the outer zone of the medulla have principal and intercalate cells, whereas tubules in the inner zone have only principal cells. Several medullary collecting tubules join each other to form the large, 200 to 300 gm in diameter, papillary collecting tubules, ducts of Bellini, that open at the area cribrosa of the renal papilla to deliver their urine into the minor calyx. Papillary collecting tubules are formed by a simple columnar epithelium composed of principal cells only. These cells possess ADH receptors, and if ADH binds to these receptors, the cells place aquaporin II channels into their membrane and become permeable to water and to urea. As water leaves the lumina of these tubules and enters the renal interstitium, the urine becomes hyperosmotic and low in volume. Acute tubular necrosis, evidenced by engorged kidneys and focal necrosis of the kidney tubules, may be caused by nephrotoxins or ischemia, resulting in acute renal failure. Prompt correction of the insult can lead to rapid recovery as indicated by increased production of urine and reduction in serum creatinine. Progressive, rapid, irreversible renal failure has been shown to be caused by the use of a weight reduction regimen that includes the Chinese herb Aristolochia fangqi, a family of plants that contain aristocolic acid. Renal cancers have also been documented in patients using this herb to lose weight. Most of the patients involved were overweight, middle-aged women. Many health-conscious individuals use herbal supplements or remedies without informing their physician or other health professionals because the compounds they are ingesting are available over the counter, and they wrongly believe these are natural. It is always wise for health professionals to inquire if patients are taking any over-the-counter supplements. The renal interstitium, the uriniferous tubules and the rich vascular supply of the kidney are completely surrounded by slender elements of connective tissue, known as the renal interstitium. Only 7% of the cortical volume and no more than 30% of the medullary volume is composed of connective tissue. Renal circulation, the renal artery, Fig 19.4, a branch of the abdominal aorta, bifurcates into the anterior and posterior divisions, which in turn branch to form the 5 segmental arteries that enter the kidney at the hilum. Segmental arteries do not anastomose with each other. In a case of blockage, blood flow ceases to the region of the kidney supplied by that vessel. Each segmental artery gives rise to lobar arteries, which branch to form 2 or 3 interlobular arteries that pass between the renal pyramids to ascend to the corticomedullary junction, where they form arcuate arteries. These remain at the junction of the cortex and the medulla as they distribute over the base of the renal pyramids to give rise to numerous interlobular arteries. The terminal branches of the arcuate arteries also become interlobular arteries. Interlobular arteries ascend into the cortex about halfway between neighboring medullary rays and provide many branches that serve renal corpuscles. These branches are the afferent glomerular arterioles that are responsible for the formation of the capillary bed, or the glomerulus, of the renal corpuscle, see Fig 19.4. The terminal branches of some interlobular arteries become afferent glomerular arterioles, whereas some terminate just deep to the renal capsule to participate in the formation of the capsular plexus. The glomerulus is drained by the efferent glomerular arterioles, EFGs, which is why the blood pressure is higher within the glomerulus than in most other capillary beds, see Fig 19.4. EFGs of cortical nephrons are responsible for the formation of the peritubular capillary network that supplies the tubules of the cortical labyrinth. These capillaries, whose endothelial cells manufacture erythropoietin, are drained by the arcuate vein, see Fig 19.4. EFGs of juxtamedullary nephrons each branch to form 25 long, hairpin-like capillaries that extend into the medulla as far as the renal papilla. The descending limbs of these capillaries, the arterioli recti, have narrow lumina, whereas the ascending limbs, the venae recti, have wider lumina, and they drain their blood into the arcuate veins. Together, the arterioli and venae recti are known as the Vasa Recta, and they envelop the medullary regions of the uriniferous tubules. Their role in urine concentration is described subsequently. Arcuate veins return their blood into the interlobular veins, which deliver their blood to interlobar veins and then to renal veins, see Fig 19.4, that drain into the inferior vena cava. Mechanism of urine formation. Every 5 minutes, the entire blood volume passes through the 2 kidneys. About 1,250 ml of blood enters the glomeruli per minute. Because the glomerulus is an arterial capillary bed, blood pressure is much higher than in most other capillary beds. This and other factors exert an average of 25 mm of Hg, filtration force, compelling the fluid component of blood out of the capillaries and into Bowman's space, where it becomes known as the glomerular ultrafiltrate. 125 ml of ultrafiltrate enters Bowman's spaces per minute. The ultrafiltrate reaches Bowman's space by passing through the filtration barrier composed of endothelial cells of the glomerulus, stops particulate matter greater than 90 nm in diameter. Fused basal lamina, stops macromolecules greater than 59 kDa. Filtration slits of the podocytes. The basal laminae, similar to a filter paper in a Buchner funnel, would become rapidly clogged, but as intraglomerular mesangial cells phagocytose the basal lamina, the podocytes and endothelial cells replace it. Renal infarcts are common in patients with sickle cell anemia, in which smaller vessels become occluded by the malformed erythrocytes. The extent of the damage is determined by the vessel being occluded. Fibrodysplasia, fibromuscular dysplasia, is a condition of unknown etiology that affects young women. The renal artery becomes narrowed because of the deposition of fibrous connective tissue at several sites in the wall of the artery. The stenosis is responsible for hypertension and should be suspected in young women who develop high blood pressure. This condition responds well to angioplasty and usually does not recur. Mechanism of urine formation. Cost resorption occurs in the proximal tubule, and the recovered material enters the capillaries of the renal interstitium to be returned to the bloodstream, Fig 19.sa and b. Most ions are resorbed secondary to the action of sodium pumps located in the basolateral cell membranes of the proximal tubules, 67% to 80% of Na, Cl*, and HO is resorbed in the proximal tubule, reducing the volume without affecting the osmolarity of the ultrafiltrate. Additionally, almost 100% of HCO3 is resorbed, and 100% of the proteins, glucose, creatine, and amino acids is returned to the blood. Juxtamedullary nephrons have a long Henle's loop and, via a countercurrent multiplier system, establish an increasing osmotic gradient extending from the corticomedullary junction to the renal papilla. The simple squamous epithelium of the thin descending limb of Henle's loop is permeable to water and partially permeable to salts. As the ultrafiltrate descends, it loses water, increasing its osmolarity, see Fig 19sa and b. The relatively short thin ascending limb of Henle's loop is mostly impermeable to water. As the ultrafiltrate flows toward the thick ascending limb, urea enters the lumen, and salts leave the lumen. The thick ascending limb of Henle's loop is composed of a simple cuboidal epithelium whose cells possess apical Na/K/2Cl cotransporter and basally located NAKAT posse pump and chloride and perhaps sodium pumps that drive Cl and Na* into the renal interstitium from the lumen, establishing the gradient of salt concentration that is higher deep in the medulla and lower toward the cortex, see Fig 19.sa and b. Consequently, the ultrafiltrate's volume remains constant, but its osmolarity decreases as the luminal fluid approaches the cortex. Monitoring the filtratin in the Juxtaglomerular Apparatus. As the glomerular ultrafiltrate reaches the macula densa, whose cells are rich in cyclooxygenase enzymes, COX-2, and nitric oxide synthase, it is monitored for its sodium, or chloride, concentration and for its volume. At low sodium levels, the nitric oxide synthase synthesizes nitric oxide, which, when released, causes dilation of the afferent glomerular arteriole, increasing the flow of blood into the glomerulus. Concurrently, nitric oxide and prostaglandin N, a COX-2 product, prompt the juxtaglomerular cells to release renin into the bloodstream. This enzyme cleaves two amino acids from the circulating angiotensin O, converting it to angiotensin I. The endothelial cells of most capillaries in the body, but especially those of the lung, are rich in angiotensin-converting enzyme, which cleaves two amino acids from angiotensin I to form angiotensin II. This molecule causes the constriction of blood vessels, including the efferent glomerular arteriole, increasing blood pressure within the glomerulus with a concomitant increase in glomerular filtration rate, and it causes the adrenal cortex to release aldosterone, a hormone that facilitates an increase in the resorption of Na and Cl* from the lumen of the distal convoluted tubule, making the ultrafiltrate more hypotonic. Movement of water and urea from and into the filtrate within collecting tubules. Because the collecting tubule passes through the entire extent of the medulla, it encounters the identical osmotic gradients as did the limbs of Henle's loop, see Fig 19.5a and b. The cells of the collecting tubule are impermeable to water in the absence of ADH, see Fig 19.5a, however, if that hormone binds to ADH receptors of the cuboidal cells of the collecting tubule, it induces the cells to place aquaporin channels in their cell membrane. As the ultrafiltrate descends toward the area cribrosa, it loses water passively, and in the inner medulla loses urea, also passively. The urine is reduced in volume and becomes more concentrated, see Fig 19.sb. Additionally, the urea concentration of the interstitium of the inner medulla is increased and is responsible for the high concentration gradient of the inner medulla, see Fig 19.sb. The Vasa Recta, composed of the narrow, descending arterioli recti and the wider, ascending venae recti, are completely permeable to water and salts, and the blood in both limbs of this hairpin-shaped vessel reacts to the concentration gradient in the kidney medulla, Fig 19.sc, and forms a counter-current exchange system. The Vasa Recta not only maintain the osmotic gradient of the renal medulla but also take advantage of it by taking more water and salts away in the larger volume outflow of the venae recti than are being brought in by the smaller caliber arterioli recti, see Fig 19.5c. Fankini Syndrome occurs in children whose proximal tubules do not resorb the proper amount of glucose, phosphate, bicarbonate, and amino acids, resulting in acidosis, dehydration, electrolyte imbalance, proteinuria, rickets, osteomalacia, and growth failure. This syndrome could have various causes, including a hereditary component, such as hereditary fructose intolerance. The use of expired tetracycline, whose decomposition product, anhydro-4-tetracycline, causes reversible tubular dysfunction, heavy metal poisoning, and glue sniffing, and certain over-the-counter Chinese herbal medicines have also been implicated in the development of Fankini syndrome. The excretory passages of the urinary system consist of the minor and major calyces, pelvis of the kidney, ureter, single urinary bladder, and single urethra. Calyces and ureter, each minor calyx, lined by transitional epithelium, receives urine from the area cribrosa of the renal papilla. Deep to the epithelium is the lamina propria surrounded by a thin smooth muscle coat, whose contraction forces the urine into a major calyx. Except for their size, major calyces resemble the minor calyces and the renal pelvis. The ureter, approximately 30 cm long and 0.5 cm in diameter, is lined by a mucosa whose transitional epithelium lies on a lamina propria composed of fibroelastic connective tissue, Figs. 19.g and 19.7. An inner longitudinal and an outer circular layer of smooth muscle cells form the muscular coat of the ureter, and its peristaltic contractions deliver urine into the urinary bladder. Urinary bladder, as the urinary bladder becomes distended with its stored urine, its impermeable transitional epithelium becomes thinner and flatter, see Figs 19.6 and 19.7. Its large dome-shaped cells also become flatter, and the plasma membranes unfold, so that the thick plaque regions are no longer folded into the cytoplasm but rather form a mosaic of thickened plaque and thinner interplaque regions, accommodating the increasing urine content of the bladder. The trigone, the smooth triangular area of the bladder mucosa, has three apices, openings of the two ureters. The urethral orifice, where occasionally mucus glands reside in the fibroelastic connective tissue. The muscular coat of the urinary bladder is composed of inner longitudinal, middle circular, and outer longitudinal layers of smooth muscle that are frequently interlaced and are indistinguishable as distinct layers. The internal sphincter muscle of the urethra is formed by the thick, middle circular layer. A fibroelastic adventitia surrounds the muscle coat. Urethra. The urethra delivers urine from the urinary bladder for voiding. The female urethra is shorter than the male urethra. The female urethra is approximately 5 cm in length, see Fig 19.6, it is lined by transitional epithelium in the vicinity of the urinary bladder and by non-keratinized stratified squamous epithelium along the remainder of its length. Mucus litre glands are present in its fibroelastic lamina propria. The male urethra is approximately 20 cm in length and has three regions, the prostatic urethra, the membranous urethra, and the penile, or spongy, urethra, see Fig 19.7. The prostatic urethra traverses the prostate gland and is lined by transitional epithelium. The membranous urethra traverses the urogenital diaphragm and is lined by stratified columnar epithelium, with patches of pseudostratified columnar epithelium. The penile urethra traverses the entire length of the penis and is lined by stratified columnar epithelium, with patches of pseudostratified columnar epithelium, until the glans penis, where its epithelium is stratified squamous keratinized. The lamina propria is composed of a fibroelastic connective tissue with mucus-producing litre glands in all three regions of the male urethra. Renal cancers. 10% of renal cancers are transitional cell carcinomas of the calyces and pelvis of the ureter. Renal cancers are frequently associated with much more common transitional cell carcinomas of the urinary bladder. Acute uncomplicated urinary tract infection, UTI, occurs frequently in women, involving 11 million women per year in the United States, but fewer than 10 per 10,000 men younger than age 50 per year. Most commonly, in healthy, young women, the cause of the infection is enteric bacteria, usually Escherichia coli from the rectum, entering the urinary bladder through the urethra. Clinical symptoms include dysuria, burning, and pain sensation on urination, increase in the frequency of the urge for urination, and pain in the suprapubic regions.